Hello guys, good evening. So we are continuing with the same momentum. We are going to talk about another newer drug in ophthalmology. In fact, this is not a new drug, so to say. This is actually an old drug in a new bottle, like an old wine in a new bottle. So we've got this drug which is going to prevent a refractive error. Now, can anyone tell me what kind of refractive error are we talking about, which can be prevented in childhood? Yeah? Yes, so we're going to talk about myopia prevention or the arrest of progression of myopia in childhood. So what is the drug and how does it act? So a few things, okay? So first is there are a few drugs that have been tried in the prevention of myopia in children. So one is atropine and another is pyrazipine. Now pharmacology, you know the action of atropine. Now atropine is a non-selective anticholinergic, non-selective reversible your muscarinic receptor antagonist, right? That means it is going to block all the receptors M1 through M5, whereas pyrazipine is a selective M1 receptor blocker. Now pyrazipine has been given up. We're going to exclusively talk about atropine in myopia prevention or the retardation of myopia. Okay, so just to revise whatever I've just told you. So the drugs that are used in the prevention of myopia, one is atropine, which is a non-selective antagonist and muscarinic antagonist, and pyrazipine, which is not used nowadays though, it's just for completion. It's an M1 receptor antagonist, okay, pyrazipine. Now we are going to talk about atropine. Now let me start with what you already know about atropine. Now about atropine, all that you simply know is it is a parasympatholytic, that is, it is an anticholinergic drug, right? So, and it is a reversible competitive antagonist of the muscarinic receptors. That's very important, both from your pharmacology point of view and also from your ophthalm point of view. Yes, it is a cycloplegic, and because it is a parasympatholytic and not just cycloplegic, it is also a passive mydriatic. Now what do I mean by, thank you Bhuvi, so not just a cycloplegic, it is also a mydriatic. Now why am I saying it is a passive mydriatic? Because it inhibits your sphincter pupillae and indirectly allows your dilator pupillae to act, thereby causing dilatation of the pupil. So it is a passive mydriatic. Now coming to the point here, atropine. How does atropine act on or it prevents myopia progression? Yeah. So there are two mechanisms. So let's divide it into accommodative mechanism and non-accommodative mechanism. Now you all know accommodative tone in children is very high. The ciliary tone is very high. So the accommodative amplitude is very high. So they can constrict so much. So when you accommodate, refractive power is getting added to the refractive power of the eye. There's more refractive power added, right? So when the ciliary tone increases during accommodation, there is a lot of D that is getting added. So when the D increases, the F will decrease, right? So there is the image which is getting focused in front of the retina. So that is also another reason for this myopia in children. Yeah, it can be a pseudo myopia as well. So now your atropine abolishes accommodation. So it abolishes the ciliary tone and they say the image moves back. So this was one hypothesis, although it is not really, there's no evidence to it for the accommodative mechanism for this myopia prevention. So that is one, okay. So there is this accommodative mechanism which I've just explained to you. Yeah. Now there is a non-accommodative mechanism which is into two ways. One is a muscarinic pathway and a non-muscarinic pathway, because it is a muscarinic receptor antagonist, right? So now when it is through the muscarinic pathway, it acts on all the three coats of the eyeball. Remember this way. So it's going to act on the retina, it's going to act on the choroid, atropine, and it's also going to act on the sclera. Now this sounds a little weird, right? Because we've always heard of it acting on the ciliary muscle and the sphincter. That's it. So now this muscarinic pathway is going to act on the retina. Now where in the retina? So in the retina, primarily it's going to act on amacrine cells. Have you heard of amacrine cells? Yes. Now amacrine cells are the only, yes, very good, Bhuvi. F will decrease. Yes, I didn't see your comment, beta. So now coming to what happens on the amacrine cells. Now amacrine cells, you all know it releases dopamine. Yes, that happy hormone. Now dopamine is very important in the development of myopia. Why? There is a hypothesis called as dopamine deficit hypothesis, DD hypothesis. Dopamine is deficient. So when dopamine is deficient, what happens? The eyeball continues to elongate. So when the eyeball continues to elongate, what will happen? Automatically the image will be in front of the retina. So there will be myopia. Yes, even though the entire refractive power of the eyeball may not be that high, still because of the axial elongation, the image will be in front of the retina. Yes. So when dopamine is deficit, there is a deficit of dopamine. Why there would be a deficit of dopamine? Because children, we don't allow them to go outside. We give them screen time to feed, to sleep, for everything. So a lot of near work decreases dopamine secretion by amacrine cells. So that is why you have to encourage outdoor activities in children. Yes. And bright sunlight, again, that also increases dopamine secretion, whereas we are not allowing the children outside at all. Increased screen time, increased near work. So all these decrease the dopamine output. Now, when you give atropine will go and bind to M1 and M4 receptors on the amacrine cells and will cause dopamine to be released. Now my eyeball is happy and it says, hey, I will stop growing. Yes. Now, that is your dopamine deficit hypothesis. So dopamine is considered as a stop signal for myopization, or in other words, it says stop. Hey, eyeball, do not grow. Okay. So dopamine is the stop signal for axial elongation. So the eyeball will not elongate. Do you understand? So that is the role of amacrine cell. Now from this amacrine cell, yes, dopamine is there, but how does it transmit to the sclera? See, sclera should not stretch, right? So amacrine is in the retina, amacrine cell is in the retina, so it has to go to the sclera. So now I need my RPE cell on the retina, which also has these muscarinic receptors, and they help in transferring the signals from amacrine cell to the choroid and the sclera. See, amacrine cell is in the inner retina. Yes or no? It is there in the inner nuclear layer. Remember the retinal layers? It is in the inner nuclear layer. So this signal has to pass through the outermost layer of the retina, RPE, to the choroid and the sclera. Yes. So RPE does this, what do you call? Like conduit. Okay. It's like a middleman. So RPE. Now coming to choroid. Now what exactly does choroid do? See, choroid and sclera are the main elements here in preventing axial elongation. So we have found out that whenever you give atropine, yes, see, atropine 1, it was binding to amacrine cells and releasing dopamine. It was binding to RPE cells and helping in the conduction of these signals. Now it also has to act on the choroid. Now it acts on the choroid and increases the choroidal thickness. Ma'am, how does this help? See, when you have myopia, what happens is, not myopia. Let's start with a newborn. You all know newborn baby is hypermetropic. All of you know that. How much hypermetropia? How much hypermetropia in a newborn? Oh, good luck for your exam in November, Bhuvi. Very good, ma. Good evening, Harish. Good evening, Mansi. Hypermetropia, yes, Bhuvi. It is around 2.5, 2 to 3 diopters, around plus 2.5 diopters in a newborn. Okay, so because the eyeball is small, now let's say this is the retina. Okay, so the eyeball is small, so the image is behind the retina in a newborn. Yeah, so there is what we call as a hyperopic defocus. Okay, hyperopic defocus. So on the retina, the image is not focused. So now what happens is the choroid thins out. When the choroid thins, the sclera gets another feedback and it also elongates. So the eyeball enlarges. So the image was here. Now the eyeball elongates because of the choroidal thinning. So the axial length is increasing. So the retina it moves back, and now the image is on the retina. It comes to focus. So this is the principle, okay, how the eyeball grows and how this choroidal thickness helps in achieving a focus. Now, when you give atropine, what happens is they have noticed that there is a choroidal thickening that happens. As the eyeball grows, there is choroidal thickening. Now, choroidal thickening and the axial elongation. So, there is a decrease in axial elongation that they have found out with atropine usage, and also increased choroidal thickness. Now, how does the choroidal thickness increase? Now, the choroidal thickness is going to increase because of this accommodative mechanism. See, when there is a decreased accommodation, it's not just action on the ciliary muscle, the choroid also, the contraction decreases. Okay, so the contraction decreases, the thickness of the choroid increases with atropine. Yes. Number two, the contraction of some non-vascular smooth cells. So in the choroidal stroma, you have smooth cells. Okay, so those contractions are also inhibited. So again, the choroidal overall contraction is inhibited. So the choroidal thickness increases. Yes. So because of all these mechanisms, the choroidal thickness increases, and it makes sure that the axial length does not elongate. So because axial length elongation means myopia, automatically myopia, no? See, this is my cornea, this is my retina, and outside sclera, of course. So if it is elongating, image will come in front of the retina, right? So that is the reason. Yes, Bhuvi, what axial myopia? Sorry, I didn't see your comment. I'm just saying it now. Okay, then what is the action on the sclera? See, sclera, it acts on the scleral fibroblasts and prevents formation of glycosaminoglycans. So in a certain way, that helps in the sclera not expanding, and also it acts on the scleral fibroblasts in certain ways, and it it influences what we call as scleral remodeling, because the sclera is literally ballooning out in high myopia, right? So because of all these actions, the axial elongation is reduced. Yes, or does not happen. So we've seen the accommodative mechanism, the non-accommodative. Under that, we've seen the muscarinic action on the retina, amacrine and RPE cells, then the choroid, then we've seen on the sclera as well. Now, what is this non-muscarinic action? So, non-muscarinic action is seen on sclera. So, directly on the fibroblasts. See, one was through the muscarinic receptors on the scleral fibroblasts it was acting, and one is direct. Yes. So, sometimes we say, no, you go through a proper channel, and sometimes we have this lateral entry. So, we have both directly through the muscarinic receptors and also through lateral entry, okay, on the scleral fibroblasts. Now, another thing is there is a cross reactivity with adrenergic receptors. So this atropine not only acts on M1 through M5, it also acts through adrenergic receptors, and they say that also paves the way in reducing the myopia. Yes. Okay. Now let's know about a few studies, especially that INI-CET is coming. So what studies helped us in understanding the role of atropine? So first was the ATOM study. Okay, ATOM study is a atropine for the treatment of childhood myopia. Okay, it's a little weird. They've chosen off O in the acronym. So ATOM study, it started in 2006. Okay, so that was ATOM 1. So in ATOM 1 study, basically they used the higher concentration, because at that time we didn't know about the low dose at all. So the conventional ones that we were using, 1% atropine, they started using. Okay, so they saw that the axial length was reduced and the diopter myopic progression also was arrested, or it was reduced when you saw with placebo. So that was ATOM 1, which was started in 2006. Then they saw now 1% has a lot of side effects. You got all these parasympathetic side effects. So they thought, okay, let's try the lower concentration. So they started the ATOM 2 study in 2012. So now they compared 0.5%, 0.5%, 0.1% and 0.01%. Okay. So these three they compared and found out 0.5% also is good, 0.01% also is good. Yeah, and 0.01 especially had a very good safety profile. They noticed all this. Yes, so all this was proven. Then they went on with very low concentration. Only the low concentrations they studied. So that is the LAMP study. Low concentration atropine, low concentration atropine on myopia progression. So here they compared 0.05%, 0.025% and 0.01%. Okay, very, very low concentrations they compared, and also along with a placebo. Okay, so it was a double-blinded RCT. Yeah. Now they found out the efficacy was very dose dependent. So even in this low concentrations, among these low concentrations, they could prove the dose dependent efficacy and the dose dependent side effect, and they found out 0.01% to be great. Yeah, it's working very well in reducing the axial length progression and also the myopia, the dioptric progression. So they said, okay, let's use 0.01%. So 0.01% is used eye drops once a day. Okay, and they've also found out when you stop it after a period of time, it doesn't regress as much, because earlier days when they were using actually 1%, they found out the initial atom 1, when you stop the atropine, it started again. Okay, so that's not great. No, that's not a good idea. So 0.01% is what we use now. It's it comes as OMNI drop. I'm not endorsing any brand here. I'm just saying because there can be some examiners who can ask you the brand. So that is given in children, not in adults, in children, and it decreases the dioptric progression and also prevents the axial elongation. Okay. Yes, any other doubts? Now I'm really thankful to one of my students who actually asked me this question. So I said, why not? Let's discuss this. So any other questions pertaining to refraction or myopia, guys? I hope you learned a lot of stuff. I'll upload all these flashcards for you. Yeah. Any other questions? Thank you. எப்படி இருக்கீங்க? திருச்சி எப்படி இருக்கு? எல்லாம் உங்க தயவு தான்ப்பா. You people give me inspired, no, to learn more. Okay, any other questions? Very good. Yeah, I'll come to Tiruchi, okay, and we'll meet. Okay, any other questions, guys? Any other doubt? So Ani, what you asked, even that 1% that was there, that was used in atom 1, it was not an ointment. Okay, it was eye drops that was used. But otherwise, generally we use atropine eye ointment in children less than 3 years because that is safer compared to the eye drops. But for myopia management, it is the eye drops. Yeah, once a day. Now, pyrazine, when it was used, pyrazine was given as a twice daily dosing, but nowadays pyrazine is not used. Any other questions, guys? Can we wind up? Okay, so I'll see you later at 9 o'clock. Yeah, 9 p.m. I'll see you with refraction quiz questions we can discuss. All right? Yeah, bye-bye.